So let's get to it. I want to introduce Dr. Gunaydin. He happens to be both an MD and a PhD, and his tenure, his resume, his CV and his tenure is very extensive. So I'm just going to mention a few things. He not only went to medical school, he is a cardiac surgeon, but he also has his PhD in tissue engineering and biomaterial science. He, in addition to being a surgeon, is a professor for cardiovascular surgery, also in the Department of Biology, in the Department of Chemistry, and the Institute of Bioengineering. He's also has been a director of medical services. He comes to us from Turkey this evening. He's also held an administrative position with the World Health Organization as an executive member of the working group. He has done large-scale scientific projects in industry as well as academia. He is well published. He has patents. And again, like I said, he's been well published in scientific journals. So without further ado, let's get to this wonderful presentation by Dr. Gunaydin.
Thank you very much, Jeff, for this very good, wonderful introduction. Today, I'm going to show the video first, and then we will discuss on later.
Hello, my name is Dr. Serdar Gunaydin. I am a cardiac surgeon from Turkey, and I work in one of the busiest hospitals in Ankara, the capital city of Turkey. I also have a PhD in bioengineering, and I also work actively in the bioengineering departments of several universities inside the country or in Europe. So we do many collaborative projects for university, PhD students, for industry. So today I'm going to talk about one of our top area for research, the cardioplegic research. And today our focus is to just talk about the severely injured heart or compromised hearts, and how are we going to deal with them, and how we solve those problems with respect to the myocardial protection in those difficult cases. So first of all, I would like to take this opportunity to take specialty care for giving me this opportunity to talk with you, to share our experiences, and to discuss the current research on this really compromised heart protection. So now I'm going to share my slides, and then we can start discussing them. Yes. Yeah. So as I said, I work in some different universities in Turkey and in Europe for bioengineering and cardiac surgery. I work in Ankara City Hospital Campus. It's really a busy hospital. We do around 3,000 cases a year, with a very different wide spectrum of cases going up to adult cardiac surgery, pediatric, transplantation, LVADs, ECMO, and peripheral arterial disease, venous disorders, and whatever. So, and today's objectives are to talk about the long-acting cardioplegic solutions in the scope of protection for the severely compromised heart. Do they work, or what can we do to make them work again? So this is my outline. I'm going to give a brief overview about the general long-acting cardioplegic solutions, and then to just focus on the new technologies we're doing research, or it's currently very much popular in the research field. So when, as the cardiac surgeons or cardiac surgical team, we are always now dealing with very difficult patients. We don't have anymore any simple case that we can finish easily without any comorbidities or whatever. So we usually are focused on frailty and very frail patients. So frailty brings us some additional chronic systemic inflammation. So this makes these patients even more difficult for the cardiopulmonary bypass point of view. So because those patients have more comorbid disease and they have many other additional factors to solve from our point of view. And when we talk about myocardial protection, it's the hot topic of cardiac surgery for over years. When even I was a resident, well, said 35 years ago, we were dealing with myocardial protection at that time. And then within this 35 years, we're still focusing on the new concepts in myocardial protection. So there are about more than 80,000 papers in the literature with respect to yesterday's search. And most of them are based on adult cardiac surgery, of course, and single dose techniques are becoming more and more popular now in those cases. If you look down, let's say 3 years ago, the number of papers was not that much, and now it's really exceeding over 300 papers. So, and the compromise function is covering nearly 1/4 of all those papers. So it's a hot topic. And the single dose techniques are becoming more and more popular in the recent, let's say, 5 to 10 years, when they're at this kind of, especially, of course, the del nido cardioplegia, to be transferred from the pediatric side to the adult side in covering all adult surgery, including CABG, and then that becomes many very different types of discussions. But still, with respect to the papers or with respect to the surveys, blood cardioplegia is still one of the most popular solutions in the world. Even with respect to the papers you can see in Europe, in Australia, in Africa, or in Asia, it's still the St. Thomas solution, or blood cardioplegia is still a very much popular solution to use. And this is also a paper from my dear friend Al Stemmers. And you can see the blood cardioplegia was still the most popular one in between, among 16,000 patients. So the two single dose techniques are usually based on del nido, HTK. We don't have much experience in our country from microplegia, so I can only talk about these two, and of course blood cardioplegia. So as you can see, for the adult case, we don't have sufficient data to support 100%. Yes, you can use the single dose solutions in every type of adult surgery. Not still, from my point of view, enough evidence to talk about, because we don't have any data on the long-term outcomes. So everything is okay. Usually there are many research, as you can see, many kind of systematic reviews, meta-analysis, and everything to compare the single dose techniques with, especially with respect to blood cardioplegia, one of the most current ones, St. Thomas or whatever. And then the results are always saying the same. Of course, these are new meta-analysis that was published in 2023, 2022 for del nido, for HTK, and it doesn't matter. The results are always equivalent or better in early outcomes in pediatric case, very much similar in early outcomes of the adult surgery, still conflicting data on adult CABG population, but when you talk all about them, very limited parameters are studied to compare, like troponin levels, temperature, delivery method, or something. So we still need some more data. And let's come to the severely compromised heart. As we talk about, we are dealing with very difficult patients, frail patients with low ejection fractions, even before surgery, because they all have many different cardiologic interventions, and finally they come to cardiac surgery. So as you can see in this paper, which was published recently in 2023, they compared nearly 200 conventional and 100 del nido procedures in the severely low ejection fraction hearts, and they don't see any difference. So this is, of course, another example of the current literature. So, and this is a very famous quote from the Rumi, a philosopher from the Middle East, and I say that everything said yesterday is okay, but we have to say new things right now, especially in this severely compromised sites. When you check the literature, and also we are focusing on the new topics in the literature, the first thing is, let's start from the experimental side, come to the clinical side. So the first idea is to understand the endothelial function to protect the heart, because when you're dealing with frail patients, that means your close-ramp time will be longer, and you have some additional support like the balloon pump, the ECMO, or whatever. So you need to be prepared for a long-term protection, especially theoretically, before the beginning. So The coronary endothelium is the most important point, most important place to secrete any hormones you can even think about to protect the heart. So, but of course, the cardiopulmonary bypass is an insult to this coronary endothelium. So that means that interferes the secretion of many hormones that will protect the heart. So you need to find some ways to protect the heart. So there are many different studies, and we also did one that was published in JACT. We just checked the impact of different cardioplegic solutions on the endothelium. So it was a lab study. We chose 3 different cell lines to mimic the heart. So one of them was the primary neonatal cardiomyocytes to just give us a presentation of the neonatal or the pediatric heart. The HUVEC cells, the human umbilical vein endothelial cells, to resemble the adult heart endothelium, and L929 as a myofibroblast, just giving a representation of the heart skeleton itself. So we just created a cardioplegic application. That's the baseline. This is the kind of place that we just have these places to represent cells, and then we put the solutions on them, and we just check the viability and some other parameters on these solutions. So we had the baseline, 100 minutes of the ischemic time, and then 2 hours of the rewarming time, and then we just follow up those cells up to 2 days to understand the long term. So when you think about 48 hours in the cell culture, that means represent you to cover up, let's say, more than 1 month in the real life. This is, of course, an assumption that's 100% true. So we just try to understand these different examinations. The MTT test is the cell viability. Are those cells viable at the end of 2 days? And we stain them with microscopy, and then to understand the early apoptosis, the cell death, and necrosis. And we also try to understand the cytotoxicity. If you give more solutions, are they toxic for the cells or not? So, of course, this is a 2D experiment covering only the cells of the heart, not the skeleton itself. So with respect to fibroblast, the skeleton of the heart, we can understand that in the long term, the control solution is, of course, the best solution that we use as a control in the cell culture units. They are, of course, worse than the control solution, but the single dose techniques are going well in the long term. And for adult cardiac surgery, again, the single dose techniques are very good in the long term to protect the heart up to 48 hours, especially from the HTK cardioplegia. And this is the protection for the pediatric hearts, the resemblance, of course. And in the long term, you can see that the single dose techniques are both Dalnido or HTK works very good with respect to control in the long term. And these are the staining representations. The green cells are viable. The red cells are necrotic cells or apoptotic cells. As you can see, in the long term, St. Thomas cannot go further. Blood cardioplegia works very well with respect to the one single dose. The HUVEC is the adult cardiac surgery, works perfect for the single dose. And even blood can go up to 48 hours. And this is the pediatric cell lines, and St. Thomas and blood in the long term doesn't work very well in those cases. And that's not very much toxic in any of the solutions up to 2 days. So, and then another point in the cell point is the mitochondria. They are the most popular topic, hot topic now in cardiac surgery, especially from myocardial protection, a mitochondrial cell transplantation. It's a hot topic, you may have heard of it. So, and the idea that's put is that the mitochondria are the most important points to protect the heart, especially in the long term, to control the mechanisms, the metabolism. So if you destroy the mitochondria with the ischemic time, you don't protect the heart very well, so you have a problem. And then, of course, we try to demonstrate this in the mitochondrial point of view. We're going to present this in the STS Coronary Conference in June and in ISMICS, the Invasive Cardiac Surgery meeting in Athens this year. So these are 2 different studies. So we check for the mitochondrial integrity and viability in the long term, comparing different cardioplegic solutions. And you can see here, HTK, Dalnido, and blood cardioplegia. And in the long term, you can see the mitochondrial content works very well for blood and HTK. in the beginning, the needle is okay, but in the long term, after let's say 90 minutes, it doesn't work very well to protect the mitochondria. And this is the ISMIC study for the minimally invasive cardiac surgery, very much similar setup to talk about the mitochondrial integrity and viability in the long term. And again, very similar results. The single dose techniques are okay in the early period, but in the long term, HTK goes to some point, but after that, even the blood is very much same with those two techniques. So as you can see, the mitochondrium is a new field that you can focus your research on, especially in the compromised hearts. And how about the hemodilution? So the most important concern of those solutions are the hemodilution, because you deliver, let's say, 1 liter, 2 liter fluid in less than 7 minutes or 5 minutes. So it's really a burden for the heart. So we also did a lot of studies, again, on the cellular level for the endothelial, glycocalyx, and aquaporins. So what are they? So this is a paper published in Innovations to especially focus on redosing. That's a very important point that I want to discuss later. So we compared two different patient populations of 100 patients in each group, the nido HTK, and we checked for the redosing. If these patients are redosed, so we go on further to understand the glycocalyx protection and aquaporin response. So glycocalyx is, again, one of the most popular topics now. It's the known, let's say, the oldest known membrane layer in the human cell. This goes back up to even 1700s. Those scientists discovered there's a kind of a layer, and that was glycocalyx. So if the glycocalyx layer is broken on the endothelium, the glycocalyx will come out of the cell, and this will bring the problem because you will lose the integrity of the cell, and this is the problem. Aquaporins are the molecules that are dealing with the fluid overload in the cell. So when the fluid is coming to the cell starts to produce aquaporins to deal with those cells. And when this fluid is excessive, the number of aquaporins is not enough, then there will be cell edema and cell destruction. So this may give us some idea about the hemodilution effect on the cardioplegic techniques. So we search in this study for the syndican level. It's a just resemblance of the glycocalyx in the blood. As you can see, in the redosing period, if you give another dose, the only lidocaine cannot protect the heart in the long term, so this may be a problem that you may consider. And this is the aquaporin levels. Again, in the redosing, there is a problem. In the first doses, no problem, but in the additional doses, you will have problem with the aquaporins and glycocalyx layer protection. So this may have a problem, as you can see here, it's the redosing side. You can see the glycocalyx layers broken because the pictures are brighter on the right-hand side. So this is not good because glycocalyx layer is broken. Glycocalyx comes out and you can dye the glycocalyx and the picture is brighter. It doesn't mean it's not good. And then this is the aquaporin level. You can even see by your clearly the cellular edema on the right-hand side after using the redosing of those techniques. And again, we did a clinical study and presented in the AMSEC meeting in 2018 that we did single dose techniques, but we always do ultrafiltration at the end of the procedure for every single case. So if you can do that, we didn't have any difference in the hematocrit level. So that was the idea at that time. We say, if you use full dose, single dose techniques, you need ultrafiltration at the end. Again, this brings the idea of lowering the delivery dose of those techniques. So this was presented in ISMICS and the EACTS meetings in 2022. And the idea was to give only 1 liter of Dalnido or HDK to protect the heart only for 1 hour. So our idea was simple: 1 liter for 1 hour. If you need more time, you can give a delivery dose again. That time, for example, you can give ½ liter for half an hour. So is this the working idea or not? So we checked for this for, again, 100 patients in each group, comparing with the blood cardioplegia. Why are we doing this? Because we need to overcome the concern of the hemodilution, or we don't need LA venting, so we sometimes do if you have excessive hemodilution, no ultrafiltration, no problems with the sodium imbalance or the additional toxicity of lidocaine in the redosing side. So, and then we just did this, and we also added some blood in some parts for even the HDK solution. This is also a study that we're going to present in the ISMIX meeting. And so what we see is that you can see this in 92% of all population, this worked. 1 liter for 1 hour, we didn't have any problem. So now we are doing this technique to overcome any excessive hemodilution, because before surgery we think, what about the ischemic time I'm expecting? If it's 1 hour, I start with 1 liter. If it's more than 1 hour, then I give the redosing. And what type of redosing, I will discuss this later. And again, continuing with the new techniques to deal with the severely compromised hearts, and one of them is the nanomedicine. So you may have heard about the nanoparticles that you will need to make your volume smaller, and you can control nanoparticles easily. So I was still working on nanoparticles. So this is a study we done with nanoparticles with the HDK solution. So here you can see this is 2 liters of HDK solution in this still very small amount, because we created nanoparticles, we loaded them with HDK solution with the amount we want. So you can arrange those nanoparticles. So we arrange these nanoparticles to dissolve in 34 degrees, for example. So you deliver this small dose, and when the patient is 34, all complete dose will be just sold in the heart. So this is another way of protection. And you can even arrange the time of those nanoparticles to slowly release those particles, so you can protect the heart in the longer close clamp time operation. So these are all very hot topics now in cardiac systems. I don't have much time. I only give the titles, brief information, and go on. And how about the innervation perfusion mismatch? This is another new topic. So whenever you operate the heart, you do the coronary bypasses, you bring some blood in the ischemic area, you think the problem is solved? And especially the severely compromised hearts, when they have a low ejection fraction, when they have an ischemic period, myocardial infarction, not only the perfusion is disturbed, but also the innervation is just disturbed or interfered. So you can just restore perfusion, but not innervation. So this is another topic. Also, we are doing a lot of research. For example, here on the left-hand side, you see the perfusion images of the nuclear imaging of the heart before and after surgery, And on the right-hand side, you see the innervation of the heart before and after surgery. So as you can see, after surgery, these places were okay, reperfused, but not re-innervation. So this will cause some problems to you with arrhythmia, with not some kind of contraction problems after the operation. So you may also need to think about this, finding some new ways. And let's come about the long-term protection. So what are the long-term clinical outcomes? We also performed another study checking for the clinical outcomes of those single-dose techniques in the long term. We follow up those patients up to 1 month. And so let's see what happened. So it was a simple clinical trial. We just check again for 100 cases in each group to compare 2 single-dose techniques versus the control blood group. And these were very good matched patient populations in all 3 groups. So after the surgery, we put the follow-up device. It's a kind of device, as you can see here, it's very much like cellular phone device. You just put it on the patient, and we send the patients back home with this device, and we will receive 24/7 recordings from this device. And there is a button on these devices, as you can see here. So when the patient has any type of problem, he or she is going to push the button, and we have an SMS message about the problem, or something is wrong with the patient. So we have a call center like this. And so this is the report we are receiving continuously from those patients that's already gone home. So this gives us the detailed analysis of ECG, blocks, ectopic rhythms, bradycardia, tachycardia, AFib, or whenever they have an angina, they also push the button. So of course, blood pressure and the rhythm of those patients. So these are the results in 1 month. So we could only follow up to 50, 60 patients in each group. Not very much, convincing number of patients, but gives at least a kind of idea. So we would see, especially some kind of clinical differences in the long term with the AFib incidence in the Dalnido group was higher with respect to blood and the HTK group. And here you can see the total event that includes like arrhythmia, ectopic rhythms, bradycardia, or whatever. In the again is much significantly more in the Dalnido group. And again, rehospitalization rate was, of course, 9 out of 51 patients in Dalnido group. Mainly the problem was arrhythmia to bring the patients back to the hospital. So this is the graphical illustration. You can see tachycardia was more, and atrial fibrillation rate and rehospitalization rate was more in the full dose the Dalnido group, of course. And we come to the hot topic now, redosing. Now, as I've told you, we are dealing with very high-risk patients, comorbidities, so complex cardiac surgery, including valve, coronary bypass together. So, and we need more cross-clamp time. So we usually need redosing time. So redosing with what? So there are studies. If you use full dose Dalnido, and you can consider an ischemic time of what? 1 hour, 90 minutes, 2 hours, or what? So these are all still ongoing discussions on them. So as I've told you before, I always just talk about it in details, but we now use Dalnido or HTK. So blood, of course, in the conventional way, so every 20 minutes. But for single dose techniques, we give 1 liter for 1 hour. And then we start thinking about redosing if we need some more time. So all the papers are discussing for redosing now, the current papers in cardioplegia area. So what is the rationale for the redosing? And for example, this is another study to study the redosing of Dalnido to compare, and they don't find any difference in hospital mortality, dysfunction, or mechanical support. And this is our paper that was published last year in the Perfusion journal. So this time, we again studied about 150 patients with Dalnido and HTK cardio. And we follow up them because these were very difficult patients, usually patients with valve plus CABG or aortic surgery plus CABG or aortic surgery plus some additional valves. So this is a long-lasting ischemic time, and they probably need some redosing after surgery. So, and we have different redosing strategies. The first one is to redose it with cold blood. The second one to redose with the St. Thomas solution. And the controls were Dalnido, redose with Dalnido, HTK, redose with Dalnido. HTK, redose with the HTK. So the idea is to understand if we can combine, okay, we can start with Dalnido, continue with cold blood. Does it work? Or we start with HTK, continue with cold blood. Or St. Thomas. Does it work? Or it really protects the heart or not? Because it's the idea, we always think about this in our practice, of course. We give 1 liter for 1 hour, and at the end of 1 hour, we are still more things to do. How long? If I need to have some, let's say, half an hour more, what do I choose? Then, of course, I will discuss it with you. This is the outcome. As you can see, not really much difference significantly. Again, on the AFib in the Dalnido continued with the cold blood group. And not really, significantly, not very much striking differences in all those redosing regimens. And again, here you can see the troponin levels were higher in the off pump. When you come out of the pump, it was higher in the Dalnido, followed by cold blood group, St. Thomas group, and then nothing else. So with these messages, we can say, okay, you can use any redosing solution, but the timing should be discussed. That means there are different options. And I will say this one, and anybody is saying, no, this is not true. I use this one. And this is also true. It's not the mathematics. There may be more than one, let's say, not true. We cannot say true, maybe, but appropriate strategies to discuss. So, and you can think your own way. So I think full dose Dalnido followed by redosing by Dalnido has kind of some lidocaine effect in the outcomes. So if I have more than, let's say, around half an hour, I always follow with blood following Dalnido. So still, but we need some larger multi-center randomized clinical trials. So let's come briefly to the conclusions. So in these techniques to protect the heart, especially in severely injured hearts, the temperature, the delivery pressure is always important, and they're always not very much cared for. So please focus on that. The temperature should be correct, and delivery time should be correct, and the duration of infusion time, and the pressure should be checked. So for CABG surgery, if we use single dose, we certainly use, in the beginning, we were, should just say, it was a kind of option for us, but now it's a must. We always use retrograde cardioplegia, of course, 1/3 from retrograde line, 2/3 from the anterior. So if it's too much volume, if we use full dose, we usually use ultrafiltration and LA venting. But if you use 1 liter for 1 hour strategy, we don't use both. So no correction, no need for corrections for HTK, for sodium levels. Because of the lidocaine toxicity fear, I always use the half dose in the second one. And if it's a long cross clamp time, I don't follow the initial Dalnido with another Dalnido infusion. I choose usually cold blood to continue. But this is not only the way, this is our experience, and your experience may be certainly different. So what's my strategy talking all about this? So I can say for simple case, good left ventricle function, cross clamp time is less than 1 hour, you can use anything. I usually use Dalnido for 1 hour and 1 liter for 1 hour, and it works. Simple case, poor left ventricular function, cross clamp time is less than 1 hour. I usually use, if it's not a minimally invasive case, use cold blood. And for poor ventricular function, I believe it works a bit better than Dalnido only. And usually, again, every 20 minutes, or I use Dalnido again for 1 liter for 1 hour. For combined cases, good or poor left ventricular function, cross clamp time is over 1 hour. My first choice usually is going to be the HTK if I have, because of some kind of, let's say, cost issues you may not have in your hospital. But if I have, this is my first choice, to go up to 1 hour, sometimes 2 hours. But again, I use the same strategy, 1 liter for 1 hour. If it's over 1 hour, I choose again anything else to have some half an hour more or 1 hour more or whatever. For emergency and minimally invasive cases, I certainly use HTK because this is ready to use every time. And it really works very well, even in the long term. If you don't have that, of course, we then use Dalnido cardioplegia in that way. Redosing. For Dalnido, 1 liter 1 hour, followed by usually cold blood for additional half an hour. And HTK redose, sometimes with half dose of HTK, or again, with cold blood in the redosing site. So as a conclusion, I can say, the myocardial preservation concept is still open for discussion. So especially severely compromised heart, but the severely compromised hearts will be the hot topic in the next, let's say 2-3 years, since, as I've told you, we're dealing with more and more difficult patients. And single dose techniques are becoming more and more popular with the additional data coming. And this is supportive data is coming. So the future will be single dose long-acting cardioplegic solutions, that's for sure. So our data on different topics are okay, but of course there are a small patient population data for redosing, the choice of redosing the long-term outcomes, clinical outcomes, is also small, let's say 100 patient groups, but we still more studies, because long-acting solutions in the long-term outcomes is really a very good question, because this should be also included in the cost. So because rehospitalization is a cost, arrhythmia is an additional cost. So this should also be discussed within this perspective. But of course, we always have and we always need more and more evidence, and all the studies are going on. So thank you very much, and I will be discussing with you with all of my friends.
Thank you very much.
Okay, hi, everybody. Thank you, Dr. Gunaydin. I really loved your presentation.
Thank you.
I'm going to see if I can get back to our presentation here. Charles, why don't you start the questions for us? Charles, you're on mute.
Got it. Thank you for catching me on that. I have one question here, which has the most thumbs up. It was put forward. Any input on the use of a hot shot to wash out prior to the cross clamp removal? And a hot shot is I do believe is a normothermic, because that's what we do, a normothermic washout of blood to wash out the metabolites, wash out the cardioplegia, and reestablish a normal temperature in the myocardium. What's your thoughts on that, doctor?
Yes, we do hot shot in nearly every type of choice, including the long-acting solutions. So we believe it would really help to wash out. Again, we do with the normothermic blood just before the release of the cross clamp. So it's our routine.
Great.
Stephen Veit here has a question for you. Do you notice an increased need for inotropic support post-bypass when redosing with Delnido?
If we do, if you are using full dose Delnido plus another redosing, that may really be a problem, especially for the right ventricular failure or arrhythmia at the end of the operation. That's why we try to find some alternative ways to decrease the amount. So it was the idea to bring us to 1 liter, 1 hour technique, but using with full dose for Delnido really makes something wrong at the end of the long cross-clamp operations.
Great. I have a anonymous person who put forth a question. What are your thoughts on using a long-lasting cardioplegia Delnido and using a blood cardioplegia for subsequent maintenance doses to extend time only by 15 to 20-minute period?
So it was also presented in our latest research. If we start with Delnido for 1 liter, 1 hour, and if I need, let's say, only half an hour or 20, 25 minutes more, we continue with blood, or even St. Thomas works fine. So this is our technique to combine the conventional with the long-acting solutions, and we see very good results, and especially very good recovery of those hearts. So this is our way of doing that, especially if we need 1.5 hours. The first 1 hour is controlled by Delnido or HT-care, but it doesn't matter, but followed by usually by blood cardioplegia.
Another anonymous question here is for Delnido. Do you recommend an LV vent for any or 100% of your cases?
So we used to, when we were using the full dose in the initial phase, Delnido with the, let's say, targeting 90 minutes at that time for cross-clamp, we were routinely using LA vent to overcome the hemodilution, and it really worked very well. But now, as I've told you, we use 1 liter, 1 hour technique, and we don't use LA venting or ultrafiltration.
I have a question here from Christine asking, what are your thoughts about the whole blood single dose cardioplegia, i.e. using the drugs in the Del-Nido solution delivered in a whole blood solution? I guess some people call that a modified Del-Nido solution.
No, we only use the conventional Del-Nido solution 1,4, and we don't modify them.
When redosing blood cardioplegia after Del-Nido, is it your technique then to redose every 20 minutes or more since you've switched to blood cardioplegia?
Yes, if we need even 20 minutes more with the second blood cardioplegia dose, we continue in that way.
Very great. Actually, this is a question from me. When you when you use a 4-to-1 cardioplegia solution, and the normal redosing time is 20 minutes, you have if you would, the reperfusion, the removal of the metabolites, and the cooling down of the heart. And from your expertise, the keeping the heart cool is a significant component of the protection. And is there anything that you can say or think that giving these single doses that could enhance the protection of keeping the heart cool with the technique of giving the single dose?
Yes, that's a very good question. We have that problem in single dose techniques, and we continuously use the external cooling, like with ice or whatever, to keep the heart cold all the time. Especially, we are focusing much and take very much attention to use with the external cooling with the single dose techniques. It's very important, I believe, to keep the heart cold.
It seems like HTK, Jing Hu says, it seems HTK has better outcomes. Are you preferring to use HTK?
I usually use HTK in minimally invasive surgery. And as you know, the practice is, evolving from conventional techniques to minimally invasive surgery. For example, now in our current practice, even we are doing 80, let's say not 80, maybe 70% of CABG by mid-cap surgery, nearly all valves with minimally invasive techniques. So that's the reason we cannot use blood cardioplegia in those operations. So that really makes then all over 65-70% of all operations are done with minimally invasive techniques. So we really need single dose techniques. So that's the reason we cannot choose blood for every operation. So in that sense, HTK is already, preparation of Del-Nido is another issue. And so keeping it ready for an emergency or in another redosing is also an issue. So if we have an HTK, sometimes it's not available in the hospital. So we try to use that one, but not if there is not, so we always use Del-Nido.
Interesting. Here's a question from Dwight. Happens to be a good friend of mine. I'm glad to see he's online. Are you performing atrial clipping as standard practice for CABGs? And if so, are you seeing a reduction utilization of pacemaker support?
We used to do that, but it's not now available in our country. So it really worked very well. And even we had a study to show that when you use the clipping, it really helps the innervation of the heart to overcome any possible arrhythmias in the postoperative period. We were very happy to use that, but now for the, let's say, last 2 years, we cannot use, the clips are not available.
Do you know, are there, Joanne has asked this question, are there any recent studies using myocardial pH probes?
It was once very much popular, and we even tried to do that kind of research with the Curie probe maybe more than 10 years ago. But it really didn't help much for us. Of course, we can even understand, okay, especially the right ventricular is getting warmer. So as I've told you before, we always take care of by putting some more ice or cold water or whatever. So I don't think it's much popular right now, using monitoring the pH of the heart.
This is a question for me. Back in the day, myocardial temp probes used to be a big thing. There's little, they would call them pins or stakes, and they'd place them in the myocardium. Has that been a part of your experience on looking at seeing how protected the myocardium is, since you may or may not have a good understanding of how perfused the heart is getting during the delivery of cardioplegia?
Yes, that's a good point, and that may really help much. But it's practically not very easy to use all those pins during the operation. So we couldn't really get full efficacy of using those types of pins and needles to check the temperature of the heart or the protection estimation of the heart. So theoretically, it should work perfect, but in a practical way, we don't have that much success.
And while we're on the temp probe, and you may have answered this, Dr. Gunaydin, I'm sorry if I missed it. We did talk about keeping the heart cold. However, do you feel with blood cardioplegia, there's an ideal delivery temp? I'm sorry if you answered that. Do you feel there's an ideal delivery temp for blood cardioplegia?
Well, taking care of the temperature is important in any type of cardioplegia. So we also really continue to check the ideal delivery temperature of those cardioplegic techniques. So it should be, checked and monitored.
Do you feel there's a temp as a follow-up that's too cold? In other words, we know the temperature does shift the oxygen dissociation curve. Do you feel there's a temperature where the oxygen might be too tightly bound and doesn't get released?
There may be, but I don't think the temperature may drop down to that level during the cardiopulmonary bypass. I believe it should be, very much different. So to do those type of harming to the heart. So we never see that type of outcome in our practice.
I have a question here from Manuel asking about, have you ever used or have you come across someone using 1 to 4 HTK to avoid coronary bleaching?
Yes. So that was the initial idea. That was, a question for me before in one of my presentations. And then the perfusionist says the surgeons are always complaining when they use crystalloid solution, they cannot see the coronaries during the perfusion. So I didn't find it logical at that time as a surgeon, but I tried. And so maybe we are the pioneers to use 1,4 HTK solution. And really, in some hearts, not every time, it really helps the visualization of the coronaries during the perfusion of the cardioplegic solution. So when we try to practice this, and some other surgeons see that we are doing that, and I heard some surgeons really are now very much looking forward to do that, and then they are happy to see the visualization of the coronaries by using 1,4 blood HTK.
Thomas Martin wants to know, do you have any anecdotal comments on postoperative AKI rate on the 1 liter, 1 hour, any lower incidence of maybe postoperative AKI with the reduced volume, or comment on volume of Del Nido and HTK in relation to AKI rate?
That's also a very good question. So our number of cases in those studies are not enough to say that clearly. but especially in very compromised hearts and in very high-risk patients, if you use full dose, it really makes a kind of the incidence of AKI much more. So, but this is only an experience, not a scientific data. But of course, this volume overload, especially in those frail patients, makes a lot of difference, the high incidence of AKI.
Let's see. I think I just got one more that's coming up here. And just by the way, I'm just coming across a lot of these. Many people are dropping their thanks for you giving us your time and your attention, your expertise, and what a wonderful presentation you gave here. And that's what I was in the middle of reading. But your thoughts of right here, if price or availability from an anonymous person was not an issue, should we use it more frequently? It seems to me that HTKA reduces inflammation.
Well, we don't have that data, but in overcoming inflammation is a very good way of protecting heart, as I've shown. Even the frail patients has more inflammation, and you put them on cardiopulmonary bypass, and you invite more inflammation. So this is unfortunately an inflammatory process. So if any solutions like HTK, includes some amino acids, so of course that may help much in those, especially patients in need, in compromised patients.
Dwight has another good point. He says it may not be a fair question, but I'm interested too, because honestly, and I've seen quite a few cardioplegia or myocardial protection presentations, and no one really, until I saw it in your presentation tonight, addressed the mitochondria. And like he said it may not be a fair question, but is anybody working directly on increasing the recovery rate of mitochondrial function to improve ATP production following myocardial stunning?
Yes, and the Boston Children's Hospital and the many researches conducted by Dalnido Group also has papers for mitochondrial transplantation in those compromised hearts of pediatric patients. And we also published a book this year on the title of the book is Mitochondrial Transplantation, to deal with those patients. And so we started now in only selected patients, not many. They are compromised hearts. And for example, we used to do, once the stem cell transplantation was very much popular and we were dealing with that at that time. But this time we just prepare the mitochondrial content from the patient and we transfer them into the compromised hearts. Let's say we did only a few patients, but we really see very good results. But this is only a new study, the pioneering study that may have a feature. But according to my experiences, I can say the mitochondrial transplantation looks much more promising than the stem cell transplantations in that sense.
Here's a anonymous question, and actually one that I was thinking of also. When you give a hot shot, how long do you give it? Personally, I just want to say I know surgeons that give it until they actually. I'll wait for your answer. What do you recommend as far as a hot shot, and how long?
Usually, we give it for example, the proposed delivery time for HTK by the company is 7 minutes, but it's too long for us. We cannot wait that much. So we usually do it in 4 minutes. So for hot shot, we also do it for 4 minutes.
Great. I personally work with some that love to give it just for a specific time, like 4 minutes, and others that love to give it until they start seeing some myocardial recovery and something like that. So that's great. Thank you for letting us hear that. I'm going to take that home in next case and pass that along to my surgeon.
I think that's a good point. I think that should be something we really kind of look at as well, because there are a lot of different ways that people are giving hot shots. And I haven't really seen anybody really talk about that. I mean, we give hot shots, we give a liter for a hot shot, and it a lot of times spans 10 minutes or more. And yeah, we do see resumption of the heart before we take the clamp off. So that might be something interesting to look in techniques of trying to reverse the oxygen debt for a long or a prolonged clamp time as well. Interesting. Angel asked a question. Angel wants to know, after a del nido dose, should we release the clamp and allow the heart to beat and recover a little bit, and then reclamp for an alternative cardioplegia if we need to extend the myocardial protection time?
Well, that may be a good idea. We didn't do that before. I will try maybe as soon as I go back to the hospital. But we don't release cross clamp, and we continue with the other cardioplegic solution following del nido, let's say like blood or St. Thomas. But this is also a very bright idea, it looks like.
Well, we're getting to the top of the hour. Charles, you have anything you want to wrap up with one question, and then I'll just finish up here? Or...
I was just, glad to see everything that was put forth here and all these questions that have come forward. My last question, just like to throw something in there, is with the hot shot. There is one surgeon in my past that loved to give a lidocaine and magnesium as a systemically through the body just before the cross clamp came off to help stabilize the heart, prevent arrhythmias, and so on. What was your thoughts on that? And do you think that has any viability as a
if the cardioplegia is del nido, additional lidocaine may be, dangerous. I'm not sure. Magnesium, yes, I can agree, but for del nido plus additional lidocaine before cross clamp release, I'm not sure.
Got it. Thank you.
Well, we're at the top of the hour, and get this to work today. We're at the top of the hour, and I want to just thank you, Dr. Gunaydin, for such a wonderful, wonderful job. And I want to just thank everybody for attending today. I also want to let everybody know that our next month, you guys are really having a hard time getting this presentation to play. There we go. We're gonna, because it's so late in April, it's the end of April, we're going to waylay in May, and we're going to shoot for early June. Mark Martin will be talking on perfusion volunteerism. And then if you have questions, Dr. Gunaydin has provided his email. There's also my email, and Charles, if you have trouble with your certificates or anything that you need to chat with us about. Once again, I just want to thank you, Dr. Gunaydin, for a wonderful presentation. And guys, he's presenting from Turkey, which it's after midnight there. It's probably approaching 1 a.m. now. So it's just your dedication, and you're willing to give back to us. I really am grateful. Charles, thank you for co-moderating with me. Maggie, as always, thank you so much for all you do to put these on. Everybody, have a great evening and a great rest of the week. Good night.
Thank you.